have that recording on 140's website. I wanted to also let you know that questions have been previously submitted, but if you should have any additional questions, feel free to use the Q&A in the bottom portion of your screen, and we will try to get to as many of those as possible. I wanted to also extend a really big thank you for this evening's host, Beth Jacob Synagogue, located in Montpelier, Vermont, and also our co-host, Jewish Communities of Vermont. We have a great lineup of speakers this evening joining us. Dr. Marie Wood, who is the director of the Familial Cancer Program, Deputy Director of Hematology Oncology Division at the University of Vermont Medical Center. We also have Wendy McKinnon joining us this evening. She is the Senior Genetic Counselor for the Familial Cancer Program at the University of Vermont Medical Center. And then also we have Janet Rosen speaking with us tonight and sharing her personal 1 in 40 story. Janet is also a 1 in 40 board member. I wanted to quickly just thank our sponsors for making tonight's program possible: the Allergan Foundation, Pfizer, New England Development, AstraZeneca, Clovis Oncology, Tesaro, and Goldstein and Bilodeau. So before we get into our lecture, I just wanted to share a little bit more about 1 in 40 and why 1 in 40. So why 1 in 40? Back in 2016, our founder, Lauren Kordak, and also she's a dear friend of mine, sought genetic testing and counseling. The screening had showed that she inherited a mutation in her BRCA gene from her father, putting her at much higher risk than the general population of developing breast and ovarian cancer. She was advised to have risk-reducing surgery, but unfortunately, it was too late. Lauren was already in stage 4 for ovarian cancer. Given Lauren's history of breast cancer and her Ashkenazi Jewish heritage, Lauren was advised, advised to seek a genetic counselor and be screened for the BRCA gene mutations. She should have been screened many years ago, that's what I'm trying to say. In fact, many Jews of Eastern and Central European descent are not aware that they have the 1 in 40 chance of having a mutation in the BRCA gene, excuse me, that puts them at much higher risk than the general population of developing breast cancer, whether that's male or female, ovarian cancer, prostate cancer, and other hereditary cancers. 1 in 40 is dedicated to stopping BRCA-related cancers in its tracks. We are a nonprofit organization that raises awareness of the 1 in 40 risk to Ashkenazi Jews of inheriting a BRCA gene mutation and provides the supports individuals and families need to effectively manage their cancer risk. I would now like to introduce Sarah Zwegas. I hope I said that right, Sarah. Sarah is the program director of Beth Jacob Synagogue in Montpelier, Vermont. She lives in Montpelier with her family and felt it was important to pursue genetic testing for the BRCA gene after becoming a mother to her son, Sam. Sarah?
Hi, well, first off, I want to thank everyone for coming tonight, and I really want to thank Allison and 1 in 40 for helping us put together this really important and informative webinar. And I want to thank Dr. Wood and Wendy McKinnon for coming and joining us from UVM Medical Center and lending their expertise and their time. And also Susan Leff from Jewish Communities of Vermont for co-sponsoring and helping us get the word out throughout Vermont. Like Allison said, a friend of mine through Beth Jacob Synagogue told me about the 1 in 40 chance that Ashkenazi Jews have of carrying the BRCA gene or the mutation. And I had never heard of it. As an Ashkenazi Jew, I was kind of surprised. No doctor had ever brought it up to me before. And I pursued genetic testing through UVM Medical Center. And it was really a simple process. And I just felt like I wanted to invite 1 in 40 to speak with us and just to spread awareness on this important topic, because I could be alone, but I don't think I'm alone in, not having known about this. So I'm really grateful to all the work that 1 in 40 does for spreading this information, and grateful you're all here tonight to learn about it.
Thank you, Sarah. We're grateful that you guys offered to host this evening's event as well. I now would like to introduce our next speaker, our first speaker this evening, who is, her name is Wendy McKinnon. Wendy is a certified genetic counselor. Wendy is a certified genetic counselor and a senior genetic counselor. I'm just pulling up Wendy's picture here. Hold on one second, everybody. Give me 1 second. There we go. There's Wendy. So let me start over. Wendy is a certified genetic counselor and the senior genetic counselor for the familial cancer program at the University of Vermont Medical Center. She is also a member of the UVM Cancer Center and the National Society of Genetic Counselors. Wendy has worked in all areas of clinical genetics, but her focus has been on cancer genetics. She has counseled a multitude of individuals and families with inherited cancer risk, together with her colleagues at UVM, and has been involved on a local, regional, and national level in presenting on cancer genetics and actively participates in research on this topic. Please join me in welcoming Wendy. Wendy? I will stop share now if you need to share your slides.
Okay, so I think Dr. Wood is going to share my slides due to my technical difficulties. Can everybody hear me?
Yes, we can.
Am I coming through okay? Okay. Well, thank you for inviting us to speak at this event tonight. And I think hopefully by the end of our conversation that everyone listening will have a better awareness about this relationship between BRCA1 and BRCA2 and hereditary cancer. So Marie, if you want to pull my slides up there. Can't share your screen? Do you want me to send them to you, Allison?
No, I just have to find it. Just give me a sec.
Okay.
Sorry.
That's okay.
Oh, life in the world of Zoom.
I know.
Oh, I see how to do this. There we go. I just didn't scroll down far enough. There you go, Wendy.
Okay, so you want to do the full, put it in slide mode. There you go. All right. All right, so if you want to go ahead and go to the first slide, I guess I'm going to have to tell you to advance. So, so just as an outline for what we're going to talk about tonight, Dr. Wood and I work very closely together in this arena, and so I'm going to start off with a few topics, and then she's going to talk about another topic. So I think what we'll review tonight is the features that we think about with the BRCA genes, what are the contributions of BRCA1 and 2 to hereditary cancer, talk about some of the risks and modifiers associated with BRCA1 and 2, and then talk about implications for family members and this concept of cascade testing, which is the idea of once somebody gets identified as having a BRCA1 or 2 variant, how do we reach out to the family and get those other relatives interested in testing so that we can really make a difference in terms of cancer outcomes. And I will touch some about some of these emotional reactions and provide some resources. And then we'll transition to Dr. Wood, who will talk about the last point, the medical management, including screening, prevention, and treatment. So traditionally, the things that we think about associated with a BRCA mutation is breast cancer. So we know that breast cancer is common and that about 1 in 8 women will develop breast cancer on average at 8. Not so fast, Dr. Wood. My little animation. On average in the population, breast cancers happen around age 60. So when we see women with breast cancer under the age of 50, so early onset breast cancer, that raises a concern about hereditary factors. And in particular, a type of breast cancer called triple negative, which means that the estrogen, the progesterone, and the HER2 receptors are all absent in the tumor tissue. This type of breast cancer is more common in people who carry a BRCA mutation. And women who've had breast cancer more than once, so multiple primary breast cancers, either in the same or contralateral breast, not recurrences of a cancer, but multiple separate primaries. A woman who's had both breast and ovarian cancer at different times in her life or at the same time, and ovarian cancer by itself. So ovarian cancer at any age is a single indication for thinking about genetic testing for BRCA. In particular, if it's what we call a high-grade serous tumor. So ovarian cancer comes in different pathologic types, and this particular type is concerning for a BRCA mutation. When we see men with breast cancer at any age, we should be thinking about testing for BRCA1 and 2. Male breast cancer is a rare event, and about 15 to 20% of men who have breast cancer may carry a BRCA variant. And then the reason that we're all here tonight is really to talk about this link with Ashkenazi Jewish ancestry. So any of the above risk factors, but also if there is Ashkenazi ancestry. And I think there's even starting to be a push to think about testing regardless of any family history and just thinking about ancestry because of the increased rate, which I'll talk about on the next slide. Now so does that get cut off a little bit on the right with the picture, I guess if you move your, okay, so everybody can see that. So this is just a schematic of the BRCA1 and 2 genes. And so what genes are made up of chemical bases that form a sequence or a pattern that the body recognizes that turns that gene into a protein, and then that protein goes off and does a job in the body. And in the case of BRCA1 and 2, that has to do with repairing DNA when it's been damaged. And it turns out that within BRCA1 and BRCA2, there are 3 separate sequence changes that are more common in people who have Eastern European Ashkenazi Jewish descent. And the estimated risk is 1 in 40. And if you just hit the next slide, Marie, and that's just a comparison to the general population of non-Ashkenazi. Can you see that? Does it pop up on the bottom? Okay, because it's covered on my screen. About 1 in 400 individuals of non-Ashkenazi descent carries a BRCA mutation. So about a 10-fold difference in incidence of a BRCA mutation. And particularly these 3 variants are the ones that are most common in people of Jewish descent. And this just has to do with isolation of the Jewish population throughout history. These are called founder mutations, and there are many other examples of founder mutations in other genes and other genetic diseases, and this just happens to be the situation with BRCA1 and 2. But I also wanted to just touch upon this because I think, you know, when we think about hereditary breast and ovarian cancer, we really think that I think a lot of people think that BRCA1 and 2 are really the only things to think about. And recent discoveries in the past, 5 to 10 years have really uncovered that there are many different genes in our bodies that if we have variants within these genes, we may have higher risk for breast and ovarian cancer. So when people come to see us for counseling, specifically, asking the question about BRCA1 or 2, we may end up doing a number of different gene tests based on one's family history. So I think it is important to remember that while BRCA1 and 2 are important and they do carry the greatest risks, and particularly for people of Jewish descent, there are other genes that are important to think about. So I mentioned that these were factors that I think for 10, 15, 20 years, we really thought about. These were the major factors associated with with a BRCA mutation. Next slide. But I think in recent years, it's become important to know that there's also a link with prostate cancer and pancreatic cancer. And in the last couple of years, it's become a criteria for genetic testing. Aside from these other risk factors, a man with prostate cancer at a young age and with a high Gleason score, which is just a measure of how aggressive the cancer is, as well as individuals with pancreatic cancer, have become sort of routine candidates for genetic testing. Next slide. And this is some early work that was done around 2016, which really highlighted that link with the BRCA and inherited prostate cancer. And this was a study out of the University of Washington looking at about 700 men with metastatic prostate cancer. They looked at 20 different genes that had been linked with DNA repair, and they found that about 12% of that group had a variant in one of the genes, but the predominant gene was BRCA2. So I think this pie chart really highlights that there is this strong link between inherited prostate cancer and BRCA2 in particular, but BRCA1 with a lesser extent over in this part of the pie chart. So in 2018, it became a recommendation through something called the NCCN, which is a national group that makes guidelines in cancer care to test all men with metastatic prostate cancer with genetic testing. Dr. Wood will talk a little bit about how that information might translate into screening and prevention. Next slide. And sort of a similar study that was done with pancreatic cancer. So a large group of unselected patients with pancreatic cancer were studied looking at about 24 different genes that are associated with DNA repair. And about 14% of those patients were found to have a particular mutation in a gene associated with increased risk. And in this study, BRCA1 and 2 both played a significant role, but another gene referred to as ATM also came back as being an important gene. And this is a gene that's associated both with breast cancer and pancreatic cancer. But again, the importance here about thinking about BRCA1 and 2. Next slide. Oh, did we lose Marie? Next slide. So just as a summary, these are some of the risks that we think about associated with a BRCA mutation. And again, this is regardless of ethnic background in any individual who is found to carry a mutation within BRCA1 or BRCA2, we see an elevated risk for breast cancer. And you see quite a range here from 46 to 87% with BRCA1 and 38 to 84 with BRCA2. And I'll come back to that range in a minute in terms of how we might better understand, who's at 38% and who's at 84%, because that's a pretty big range. And you can see that compares to the general population risk. Women who develop breast cancer and learn that they have a BRCA1 or 2 mutation are at risk for developing a second breast cancer. And these risks are outlined here within 10 years of their diagnosis and then overall by age 70. So there is quite a high risk for a second cancer to occur. And I think, again, when Dr. Wood talks a little bit about screening and prevention, plays into some of the decisions that women make about screening versus surgical interventions is often based on some of these risks. There's also a risk for ovarian cancer. The risk is greater for BRCA1, as you see here, versus BRCA2, but still significantly higher than the general population. And for men, the risk of breast cancer is really associated more with BRCA2 than BRCA1, which is also the case for prostate cancer and pancreatic cancer. So BRCA1 is really more of a breast ovarian cancer susceptibility gene, whereas BRCA2 is breast, ovary, but also male breast cancer, prostate, and pancreatic. And there's some data to support melanoma risk. I think it's not super great data. It sort of was very early, but because we feel like doing a skin exam and an eye exam are things that people are often doing, that if we caught something early, that would be a good thing. And so we often do think about screening for melanoma, particularly in individuals with BRCA2 mutations. Next slide. And this just gives another way of looking at the two genes and some similarities and differences between them. So in this graph here, you could see that the risk of breast cancer in young women is still very low. But in BRCA1, in younger women, there is a higher risk than for BRCA2, but overall, over a woman's lifetime, those two genes do have pretty similar risks. It's just that the curves look a little bit different in terms of the ages of onset. And we've seen that in our own clinic, that we do tend to see ages a little bit later in BRCA2 than BRCA1. But again, it is a lifelong risk. And if you looked at the curve for the general population, you would see that, the curve is going to be way, the average age is down here in the 60s and going to kind of go off about the 10 to 12%. So very different curves. And for ovarian cancer, the overall risks are different, with BRCA1 having an earlier age of onset and a higher risk, BRCA2 later age of onset and lower risk overall. Next slide. So, I'm not going to go into a lot of detail here, but I think this is an area that is under a lot of researchers are interested in this because that range that I showed you in that slide, that the risk for developing breast cancer, particularly in breast cancer, there's a big range. So why does someone maybe have a 30% and somebody else has an 80%? And I think we're going to start to learn that people may carry other genetic factors that may either protect them or make them more at risk. And so I think over time, we're going to learn more about how we can personalize people's risk a little bit better. And that may be really helpful in some of the decisions that people have to make based on their BRCA status. Lifestyle is an area that people are looking at in terms of things like exercise, diet, some of these things that may have an impact on how that gene expresses itself. And hormonal risk factors are things that, we really can't change. And so these are difficult things to counsel about because they're not things that you have a lot of control over in terms of, when you started your period, when you had your first baby, those kinds of things that may have some relationship with protecting or increasing risk, but not things that are easy to modify. But I do think this is an area that as we learn more about BRCA and the things that interact with BRCA in our bodies, we'll have a better sense of the specific risk for a particular individual. Next slide. So in terms of thinking of this concept of cascade testing, again, just the idea of reaching out and trying to test other family members to try and be as preventative in a family as possible. So the BRCA genes are what are called autosomal dominant, which means that all our genes come in pairs. You get one copy of each gene from each parent. And if you have a change in one of your BRCA genes, it's a 50-50 chance that it gets passed on to the next generation. So first degree relatives, which are children, siblings, and parents, all share 50% of their genes. And so that's an important concept in thinking about counseling families and who's most at risk for sharing a BRCA mutation. Next slide. Oh, go back one. So the vast majority of individuals with a BRCA mutation inherited it from one of their parents. This isn't typically something that we find new in an individual, as usually we can always trace this back in a family. But some people might say, well, gosh, there's no cancer in my family, and gosh, I don't know where this came from. And I think there are some variables that we really think about when we're counseling families that, again, that the risk of developing cancer with these genes is not 100%. So not everybody who has these gene markers is going to get cancer. And the gender of the parent. So if you inherited this from your mother versus your father, or your father versus your mother, the risk of cancer in different genders is different. So you might not see cancer. And the age of the parent, if the parents are young enough that maybe they haven't developed cancer, and maybe those parents have taken risk reduction strategies through screening or prophylactic surgery, so there isn't a cancer history, or perhaps there's early deaths in the family, so there just isn't a family history. So there are different, things that we look at in terms of the family history that can help us sort of think about that. It really is appropriate to test both parents to see which side of the family the variant was inherited from. And I think there's also some debate, instead of just testing for the specific variant, whether it be BRCA1 or 2 in the family, we are now thinking in some situation, it does make sense to do more testing than just for that particular mutation. So we really do look at the family history and make sure that we aren't missing one of these other genes that's out there that might be present in the family. Or in the Ashkenazi Jewish setting, if all 4 grandparents are of Jewish descent, we really do need to be thinking about testing for all 3 of the BRCA mutations in an individual, even if one of their parents has one mutation in that child. If you might pick up something that came from the father's side because of this 1 in 40 incidence. So, sometimes it isn't as straightforward as it sounds in terms of which gene test to pick. Next slide. And I think, one of the things that we really stress in our practice is that, this really is a family affair. And so while it's important to consider the impact of testing on all family members, we really encourage people to communicate with their families if they're getting tested, to let them know that this information may be coming. But ultimately, it is the individual's choice. And we have come across some complicated situations where there may be an individual in the family who doesn't want to know this information, but sort of maybe their child or sibling really does want to know this information. And, you know, who's right? Is it, you know, because, you know, if you test the person who wants the information, that potentially reveals the information about the person who didn't want to know. So there can be some tricky family dynamics, and it is really important to kind of get the family talking about this and understand that this really has implications for everybody in the family. Next slide. And just, you know, there are lots of issues that can come up during this process. And I think for some people, going through genetic testing can raise anxiety and depression symptoms. Some people who go through this process, particularly, you know, parents might feel guilty about the potential risk to their children. And in terms of thinking about some of the procedures that women might have to think about, it may create some self-esteem issues in thinking about breast surgeries or ovarian surgeries in early menopause. I mean, I think there's a lot of body image and self-esteem issues that can come up. And some people may feel stigmatized by having a genetic marker, that somehow this changes their perception of their health about themselves and somehow makes them feel different than they did before they had the test, even though, you know, this is something that is present at birth, it's been there their whole life, but somehow that knowledge sort of changes how they feel about themselves. And people tell us that, you know, getting information about your genetic status is sometimes like getting a cancer diagnosis, that some people really feel like when they get that information, it just brings up a lot of issues similar to when they got a cancer diagnosis. Talked a little bit about, you know, family dynamics. There certainly can be lots of issues in families. And but I do want to say that I think for many people who go through this process, it's really an empowering process. And while there may be a lot of things going on in the family and for themselves in this process, I think a lot of people find learning about their risk and being able to take action can be really empowering. Next slide. And there are some factors that can influence how people think about their risk and their reaction to genetic information. And I know Dr. Wood and I, you know, see this a lot, is, you know, when we give somebody a positive result and then talk about what their options are, oftentimes the choices they pick are based on what they've experienced in their own families. And whether people in their family have survived cancer or whether they have not survived cancer, oftentimes the choices they make are often reflected in what they've experienced themselves. And we know there are people who are information seekers and people who don't want information. And so personality traits can really play into how they look at this information. There's been data about socioeconomic factors, including things like education, can impact how people think about this information. And cultural, social, religious, and spiritual factors can impact how people think about this. So we really do try to explore a lot of these things with people and sort of help them figure out where does this information fit in with their own situation, and helping them make the best choices for them. Next slide. And these are a number of resources that we have used, you know, the 1 in 40 that we're talking about tonight, you know, Force and Bright Pink and Charcheret are all great organizations around hereditary breast and ovarian cancer and BRCA in particular. The HIS Breast Cancer Awareness Program is really targeted towards men who are at increased risk. And then there's a group out of the University of Pennsylvania called the Bassler Center for BRCA Research. And they're doing a lot of really exciting things around BRCA research. And we do provide this to all of our families to plug into their programs. So some great resources that are out there. And next slide. And that's it. Thank you.
Thank you, Wendy. I know I certainly learned a lot more this evening about male hereditary cancer. So thank you so much.
Thank you.
I now would like to introduce Dr. Wood. Dr. Wood, do you want to share your screen, or I could share mine too, just to introduce you? I have to just stop screen sharing yours. Is that okay for right now?
Sure, yeah.
Okay, great. Let me. That's Wendy. Here's Dr. Wood. So I now would like to introduce Dr. Wood. Dr. Wood is a professor of medicine at the University of Vermont Lerner School of Medicine. She's an active clinician and researcher. Her clinical focus is caring for individuals with breast cancer or at risk for cancer. She is the director of the Familial Cancer Program and deputy director of the Hematology Oncology Division at the University of Vermont Medical Center. Her research program focuses on breast cancer biomarkers and mammographic breast density. She serves as the Associate Director for Cancer Control and Population Health Service at the University of Vermont Cancer Center and the co-chair for prevention within the Alliance for Clinical Trials. Please join me in welcoming Dr. Wood.
Thank you. I now have to just switch slides. I want to be attentive to time to leave. So I know we're running a little bit late. Would you like me to cut my presentation a little bit short so that we stay on the hour, or how would you?
I'll leave it up to you. I mean, we can, the Q&A has already been fed to us, so we can,
Okay.
maybe we can shorten that so we can leave time for, I want folks to be able to hear you.
Okay.
Be able to hear our panelists, so go ahead.
So am I sharing my screen?
Yeah, yeah, go ahead. You can share your screen now. Should be able to.
Well, I see it. I hope you do, but I think you don't.
I just see your,
Here we go.
I just see your lovely face. There you go.
There we go. So as Wendy had said, I'm going to focus a little bit on medical management and talk a little bit about screening, prevention, and treatment. As Wendy, we're going to talk a little bit about breast and ovarian cancer, and talk a little bit about pancreatic, prostate cancer, and melanoma, talk about screening, prevention, and treatment, and try and consider what we do for both people with cancer and without cancer. It's really one of the first things we do is think about screening for breast cancer, and there's really great data that shows us that by adding MRI to mammograms, we significantly decrease the risk of finding cancer in between screens from 30 to 50% down to 10%. Importantly, we also increase the sensitivity of finding something when we add MRI to mammograms. Partially, that's because mammography is not particularly sensitive for women at high risk. And you can see here, when you look at the sensitivity of mammography, it's in the 40% range. When you look at the sensitivity of screening breast MRI, it's significantly above that, in the range of 70 to 96%. We also know that a prophylactic mastectomy is one of the most effective ways to reduce the risk of ever developing breast cancer. And when you look at groups of individuals, and there's a number of studies that have been presented, whether they have BRCA 1 and 2 mutations or strong family history, you reduce the risk of developing breast cancer by greater than 90% by removing all of that breast tissue. We also know that having your ovaries out, or an oophorectomy, can prevent breast cancer by decreasing that hormonal influence. We know that an oophorectomy decreases the risk of ovarian cancer by 90% or greater, and it decreases the risk of developing breast cancer by 50% when it's done for premenopausal women. This effect may be less for BRCA1 mutation carriers than BRCA2 mutation carriers. There are chemo prevention options, so pills that you can take for to prevent breast cancer. We know that there are hormonal agents such as tamoxifen, and in clinical trials, other selective estrogen response modulators. We also know that for postmenopausal women, taking one of these aromatase inhibitors can reduce the risk of developing breast cancer by more than 50%. These are drugs that are commonly used to treat breast cancer, but we also know that if you don't have cancer and you take them, they significantly reduce your risk. There are important agents that are in clinical trials. Denosumab is something that we use to improve bone density, and it's currently being studied for BRCA1 mutation carriers to look at the preventative effect. There is conflicting results about who may benefit from tamoxifen. There are two small studies. One shows no effect of tamoxifen for BRCA1 mutation carriers, and the other study did show a significant effect for women who had BRCA1 or BRCA2 mutation. So there's a little bit of conflicting data out there. The study looking at denosumab, something that builds bone density, is currently being opened at 35 sites across the country. And this is just for BRCA1 mutation carriers who would take this injection for 6 months versus placebo. And we will look to see whether they reduce their risk of ever developing breast cancer. And we will have this trial open at the University of Vermont, hopefully within the next year. Ovarian cancer screening and prevention, I'd like to talk a little bit about that. We know that unfortunately, there are tools to screen for ovarian cancer, but using these tools is not associated with a lower stage or improving survival for ovarian cancer. We do, however, know that women taking oral contraceptives reduce the risk of ever developing breast cancer by 50 to 60%. And this is when you take them for 5 years, you reduce that risk by 50 to 60%. We don't know whether hormonally implanted IUDs or Depo-Provera is specifically effective, especially for BRCA carriers. And for women using prolonged oral contraceptives and starting at a very early age, there may be some increased risk of developing breast cancer. So you have to really weigh the risk and benefits. Similarly to breast cancer, there's a study looking at denosumab again, that bone strengthening measure that is being tried in BRCA1 and 2 carriers to think about, is it helpful in reducing risk of ovarian cancer? We do know that there's that removing the tubes and ovaries actually reduces the risk by 90%. There is some residual risk of what's called peritoneal carcinomatosis, but that risk is greatly reduced. We often worry about the effects of early menopause when you take both the tubes and the ovaries out. This can have negative health consequences such as bone health, cardiovascular health, and some thinking that happens. So some emotional effects and some memory effects. It is recommended that for BRCA1 carriers, they think about having their tubes and ovaries removed between ages 35 and 40, and for BRCA2 carriers that they have theirs out between 40 and 45. You do not need to remove the uterus. It's also safe to transition into menopause with hormone replacement therapy. It's important that women remember, and their healthcare providers remember, that they should be monitored for bone density and cardiac risk. And as I'll show you in the next slide, having just your tubes out may also be an option. Just having your tubes out is called a prophylactic cell pingectomy. It has been shown to lower the risk of ovarian cancer by 50% in the general population. There's no data in BRCA populations, but it is being investigated. This allows women to then have their ovaries out more towards the age of menopause and avoid some of the early negative side effects of early menopause. There are risks. The impact of procedure on ovarian function is unknown. So just taking the tubes out may impact ovarian function. And it does require an additional surgery for BRCA1 and 2 carriers to then remove the ovaries closer to menopause. And if you're looking to reduce the risk of ovarian cancer, taking the tubes alone out would not do that. I'm going to talk a little bit about treatment options for BRCA mutation carriers. There are new medications called PARP inhibitors. These are drugs which target the deficiency in DNA repair for BRCA mutation carriers. They are very well tolerated, and there are trials that have been shown to be positive in other DNA repair genes, such as PALB2, ATM, and maybe others. These drugs, and there are multiple of them, have been shown to be effective in not only breast cancer and ovarian cancer, but also pancreatic cancer and prostate cancer. So any BRCA mutation carrier who has a cancer could be a candidate for a PARP inhibitor. As Wendy talked, there are also risks for prostate cancer and pancreatic cancer, and I'm going to talk just a little bit about screening and prevention for those. For prostate cancer, the recommendations are to begin screening at age 40 with annual prostate cancer-specific antigen, a blood test, and digital rectal exams. The next steps may be based on PSA or PSA change. So we know that if your PSA increases over time, it may be a sign that you do have prostate cancer. And it's also important to realize that PSA is different for different ages, and the cutoff for which we think about further evaluation is different based on your age. There are clinical trials that are looking at men with genetic predisposition to prostate cancer, the IMPACT study, and the preliminary results of this study do support yearly PSA screening in men with BRCA2 mutations. Remember, BRCA2 is more likely to be associated with prostate cancer than BRCA1. And there is another study sponsored by the NCI that's looking at annual PSA digital rectal exam and now an MRI of the prostate cancer as screening for these men. Thinking a little bit about prostate cancer. Oh, I don't know how I did this. Thinking a little bit about pancreatic cancer, the recommendations are generally only done if there's a family history of pancreatic cancer in your first or second degree relatives. It's recommended to start 5 to 10 years before the youngest case of cancer in the family. And what we think about for what we use as our screening tools is called endoscopic ultrasound, done annually, or there is a technique that is an imaging technique using MRI that's also in studies. There are several clinical trials. One Italian trial that has shown that annual MRCP with MRI is associated with a higher rate of identification of early disease. And there's another study looking at cancer of the pancreas screening study where the preliminary data suggests survival benefit from surveillance. I do want to just reiterate the point that Wendy made, is that when we find these mutations, it's so important to think about testing others in the family. If you're testing a patient with cancer first, as we commonly do, then it does afford you the opportunity of testing people who are unaffected and can then benefit from screening and prevention opportunities. This is just a slide from our program, which I'll leave up and say thank you very much.
Thank you, Dr. Wood. I appreciate that. I would now like to, if you could stop your screen share. Thank you. I would now like to introduce, where's Janet? I would now like to introduce Janet Rosen. She is going to be sharing her story this evening. Janet is a longtime friend of 1 in 40 and also serves on our board of directors. Janet lives in Newton, Massachusetts, and is currently the Director of Stewardship and Advancement Communications at Buckingham Browne and Nichols School. Janet?
Good. Thank you for having me this evening. So my name is Janet Burdick Rosen. I am 1 in 40, as is my younger sister and my daughter. I'm not sure if that makes our family 3 in 40 or 3 in 120, but knowing that there are many, many others like us with this distinction, so to speak, empowers me to share my personal 1 in 40 story tonight. Growing up in the 1950s and 60s with a father who was a surgical oncologist and a breast cancer specialist, I had heard of this dreaded disease, but only knew that it was a serious medical condition that required my father's compassionate care, and for particularly ill patients, a batch of my mother's homemade chicken soup. My only knowledge of a family connection with the disease was a paternal aunt who was diagnosed with breast cancer at age 32 and died at 49, my paternal grandmother who developed breast cancer at 81, and a cousin on my mother's side who developed and died of breast cancer in her mid-30s. I certainly saw no indication of this as a pattern, as in many families, or to think that cancer would ever touch our family closer to home. So it came as a rude awakening in December of 2010 when my younger sister, Lisa, aged 50 and living in Florida with her husband at the time, called to share the news that they would not be able to fly up to Boston for our annual family holiday celebration because she had just been diagnosed with stage 3C ovarian cancer and would need surgery the next day. Unfortunately, although Lisa had been complaining of vague abdominal symptoms for nearly 6 months, none of her doctors recognized the signs of ovarian cancer to consider this as a possible diagnosis until it had progressed to an advanced stage. During a post-surgery visit, however, her gynecologist, to his credit, asked Lisa whether she had considered genetic testing because he knew of her Ashkenazi Jewish background. Following testing and learning that she was BRCA1 positive, which was likely a cause or contributing factor of her cancer, Lisa shared the news with me and my older sister and suggested that we also get tested. There was no question that we would do so and that we would do it together so that we could be supportive of each other regardless of the outcome. Test results showed that my older sister was negative, but I was positive, the luck of the draw, the 50-50 draw as has been mentioned earlier, and that the likely carrier from this genetic profiling of our family was likely on our father's side, which was ironic given his medical specialty. After consulting with several local specialists, it was an easy decision for me to make to undergo a prophylactic bilateral sapingo-oophorectomy, as I was postmenopausal and had completed my childbearing. Since then, I have chosen to follow the enhanced breast screening protocol, not prepared to consider the surgical alternatives at this time, and have continued to educate myself and my family through involvement with organizations like 1 in 40 and their special mission to inform the Ashkenazi Jewish community of their heightened risk for these cancers. More challenging has been the process of convincing my daughter to consider genetic testing, knowing of her 50-50 risk and the special challenges that she would face at her age if she were to be test positive, although the reassurance and peace of mind if she were negative. My daughter was 25 at the time of my sister's diagnosis, and she had genetic counseling at the time, but opted not to be tested. She was nearly 30 at the time of her Aunt Lisa's passing after a 4.5-year valiant fight against the disease. But it took until 2 years ago at the age of 32 for her to finally be tested. Unfortunately, she also drew the same short straw as I did and is now dealing with the choices she needs to make for vigilance and prevention while she continues to work to find success in her personal and professional life. Looking back, my biggest regret is that the information about BRCA's connection with the Ashkenazi Jewish community was not known or certainly not publicized in the years leading up to my sister's diagnosis, which, had she known and been tested, might have saved her life. My biggest hope is that organizations like 1 in 40 and a growing number of others can help spread the word among the medical and Jewish communities of the need for broader testing, as well as better prevention and treatment options for future generations like my daughter. Thank you.
Thanks, Janet, and thank you for always offering to share your story with our community and to the community at large. We really, really appreciate it. Thank you. We now have time for a few questions that were previously submitted to us. I'm going to put those up on the screen, and then the panelists, we can go through them really quick, and we can decide who might be best to answer those. Let me just pull up that slide really quickly. There's Janet again. Okay, so here are some of the questions that were submitted, and then we also just got one on chat. So I don't know, maybe Wendy or Dr. Wood might want to take this one. So somebody had asked, you know, they're interested in getting tested or screened. What do they do? Do they go to their primary care? Like, how should the conversation begin with their primary care, and you know, what's the starting process for all that? If somebody is interested in getting tested, and how do they have that conversation with their doctor?
So I think that's a great question. 2 ways. One, you can actually just refer yourself to our program, and we put up that contact information. So if the slides are available afterwards, I think Wendy put together contact information. I think you can also just mention this to your primary care provider, who would also refer you to your program. To our programs. One of the things we don't recommend is to have your primary care provider do the genetic testing or do it through some of these programs that are being offered through mammography screening programs. Do you want to say anything else, Wendy?
No, so I mean, certainly our program, if you live in Vermont or upstate New York, but I don't know who all is listening, but one of the things on the slide, there's something called the National Society of Genetic Counselors. And if you just go to their website, they actually have us find a counselor. So you can actually find somebody who specializes in cancer genetics in, you know, Albuquerque or Sacramento or, you know, even internationally. So if you're looking for somebody with expertise in this area, that is a great place to try and find that outside of our region. But I agree with Dr. Wood that, you know, the counseling is really an important part of the process of understanding the implications. And we've had a number of situations of people who have gotten tested outside of a genetics program, and sometimes it's not always a good outcome in terms of their understanding of the implications, wishing they had known this before they had the testing. So just to reiterate that I think the counseling is a really important part of the whole process.
Great, and I think that kind of touches upon how folks would find a genetic counselor during this time. So just to follow up to that question. So given the pandemic, COVID-19, how is testing and screening and counseling being done during this time? Is it telehealth visits? Like, how are folks? You know, you could specifically speak to your center, Wendy or Dr. Wood, but how is that all being handled now?
Yeah,
I'll let Wendy handle that.
Yeah, we readily are using Zoom, which we had been doing prior to the pandemic. So we had a couple different sites in Rutland and Central Vermont where we had already been Zooming with folks, so they didn't have to come all the way up to Burlington. So it was easy for us to transition to doing that sort of full time. And so as long as people have ability to do Zoom, we have been Zooming with patients. And in terms of the testing piece, we can actually work with the laboratories to have saliva kits sent directly to people's homes so they don't have to go out and get exposed to get their blood drawn. And some people prefer to have a blood draw, and so we can coordinate that as well. But we have been able to get around that. And I say we've been just as busy, if not busier, during this time than prior. So it hasn't been a huge hurdle for people to get the services. And it's been working really pretty well.
Okay, thank you. I believe we've already spoke about risk-reducing surgery. Is there anything else you'd like to add to that, Dr. Wood?
No, any risk-reducing surgery is something that removes the tissue, and then you're reducing your risk to the greatest extent.
Mm-hmm. So we got, thank you. We got another question just saying, my husband's BRCA positive and has male breast cancer. What are the resources? What might be some resources available for him? Whether that's, I know, Wendy, you had mentioned his Center for Breast Cancer. Are there any other resources available for men that may have been newly diagnosed with male breast cancer?
The FORCE website has a great resources for men. They have a whole section that is of their website that is geared towards information for men. So I think the FORCE website and the Basser Research Center would have information for men as well. And then the HIS that I mentioned, that resource as well. And then obviously, you know, our center too, I mean, we're happy to often put people in touch with each other. I think often for a man with breast cancer, it's kind of an unreal situation, and often feel like, gosh, you know, this shouldn't be happening to a man. And we can put people in touch with other men who have had breast cancer or who are BRCA positive. And so sometimes those patient connections can be helpful as well. So we've often done that.
Okay, great. I just want to answer this one live question, and then we'll wrap up the questions just in the interest of time. Somebody's asking if they were tested 10 years ago and they were negative, have there been any advances in testing so that you would recommend retesting?
Yes.
Yes.
Yeah, so I mean, it depends on the history, but we are seeing a lot of people back who had BRCA 1 and 2 testing prior to 2013, and who are coming back to get these what we call multi-gene panels, where we're looking at all these other genes that I showed that slide that are now linked with other cancer, with breast and ovarian cancers. And I think the data, and Marie, correct me if I'm wrong, but there were a number of studies looking at, you know, how often did we find something important in somebody who was BRCA negative when we do these panels. And I think most of the studies, you know, were up to a 10% rate of finding something that was clinically important. So it is important for people to come back and revisit these new technologies.
Okay, great, thank you. I know we're not going to be able to get all the questions all the questions answered this evening, but we will have these slides and the recording, the slides of our presenters and the recording available on 1 in 40's website. Again, here are some additional resources, you know, that are listed on 1 in 40's website as well. You'll be able to view these again by tomorrow. This should all be up on our website. After this program, all the attendees should receive an email with a brief anonymous survey. We would greatly appreciate if you could take a few minutes to fill that out and send it back to us. I did want to let everyone know that we have another upcoming webinar taking place on September 9th at 11 a.m. Eastern Standard Time. We'll really be talking about coping, caregiving, and cancer during COVID-19. And our guest speakers will be the Virginia Thurston Healing Garden. They are based, they're a wonderful organization that's based out of Massachusetts that provides support services for those living with cancer and their families and friends. I wanted to, you know, once again, thank our sponsors for helping to make this program possible tonight, as well as our gracious host, Beth Synagogue, and our co-host, Jewish Communities Vermont, as well as our guest speakers tonight, Wendy, Dr. Wood, and Sarah and Janet. Thank you so much for taking your time to help me make you know, this program wonderful. And just, I learned a lot tonight. I hope our attendees learned a lot as well. As I mentioned, the recording will be up. Feel free to get in touch with 1 in 40 or Beth Jacob or the University of Vermont Medical Center should you have any additional questions. And once again, thank you, everyone, and have a great rest of the week.
Can I just make one comment?
Of course.
For people who are in our catchment area, in the area of Vermont, who had specific questions, I saw some about what I'm BRCA positive or I want testing.
Right.
We did put a slide up with our contact information. You can contact that, and we're happy to answer your questions.
Great. Thank you. Thank you, everybody.
Thank you so much.
Thank you.
Thank you.
Have a good evening.
Bye.